blood count recovery was initially a bit of an overlooked toxicity related to CAR T cells, and most people focus on cytokine release syndrome and immunologic toxicity, but this has actually there's more and more groups and more data coming showing that this is actually a pretty significant toxicity, and potentially this can be associated with high risk of infections due to, for example, low neutrophil count, and also impairment of quality of life due to repeated transfusions, and obviously risk of bleeding as well related to low platelet counts. So the mechanisms and the factors that are associated with slow or impaired count recovery after CAR T-cell therapy are basically misunderstood. And there was two abstracts at the ASTCT meeting that looked at this count recovery after CAR T-cell therapy, including one study from our institution. So it's important to note that these two studies actually use different criteria to assess count recovery. And I will start with the data from the Memorial Sloan Kettering Cancer Center that was presented by Dr. Tanya Jain. In this study, they analyzed 83 patients, and this included both patients who received CD19 or BCMA-targeted CAR T cells. And basically what they saw is that by 1 month, there was like a significant fraction of patients that had not recovered their counts. And platelets recovery was only observed in 51% of patients at 1 month, and in terms of neutrophil recovery was only observed in 33% of patients. And this gladly dramatically improved at 3 months, with 93% of patients who had recovered the platelets at 3 months, and 90% of patients who had recovered the neutrophil count. So this is a very interesting study, and we also presented data from our center using a restricting an analysis only in patients treated with a CD19 targeted CAR T cell product of defined composition, and we reported a preliminary analysis in 125 patients. What we saw is, using, again, slightly different criteria, we used the CIB-MTR criteria for hematopoietic recovery. So those are slightly less stringent criteria that are commonly applied in the bone marrow transplant setting. And what we saw is that the probability of platelet recovery at 1 month was 74%, and the probability of neutrophil recovery at 1 month was 80%. So slightly different numbers, but overall in a relatively similar range. And this improved again at 3 months. So what we did on top of these descriptive statistics is that we performed fairly complex multivariable modeling, taking into account some competing events, in particular, for example, having a bone marrow relapse from the initial disease, and obviously adjusting from the count prior to CAR T-cell therapy. And so interestingly, we saw in this multivariable modeling that disease type was an independent predictor for neutrophil recovery, with a better, faster recovery in NHL patients and CLL patients. As expected, the platelet count was a good predictor of hematopoietic recovery as well. And very interestingly, the intensity of the toxicity was a very strong predictor for poor and slower both neutrophil and platelet recovery. And the hazard ratio was 0.75, and for neutrophil recovery in 67, so roughly 30 to 35% increase in risk of poor count recovery per grade increase of the toxicity of cytokine release syndrome. So this is a very interesting finding. We are yet to fully unravel the underlying mechanisms. Obviously, we think the pro-inflammatory cytokines could have an effect in slowing down hematopoietic recovery, but at this stage, more data are needed.